Good evening, everyone, and welcome to Achieving Zero Overdose, Understanding Overdose Prevention and Safety Planning. I'm Aubrey Robinson, Education Coordinator for NAMI-NYC, and I'll be your host tonight. We also have my colleague, Barbara Espinoza, on, who will be monitoring the chat and sharing some resources as we go. We just thank you all for being here. Tonight, we're honored to have with us our guest speaker, Leah Harris. Leah will share critical information about overdose prevention and safety planning. This event will empower family members, community members, and healthcare professionals with tools to recognize overdose and aid in prevention. We are thrilled to put on this event with Zero Overdose. Zero Overdose is dedicated to reducing overdose events by expanding access to overdose safety planning and education for individuals and communities at risk. As you may already know, NAMI-NYC has been providing individuals and their families affected by mental illness for over 40 years. We offer free mental health classes, support in social groups, family mentoring, and much more. Tonight, I just want to highlight a couple support groups for both those living with addiction and their loved ones. NAMI-NYC's Living with Addiction and Mental Health Challenges is a virtual support group for adults living with addiction. And then we have Family and Friends of People with Co-Occurring Disorders, which is a support group held both in person and virtually for family members and close friends of people living with a mental health condition and substance use challenges. And Barbara will put both of those support groups and their information in the chat. If you have any other mental health questions or would like to learn more about our other programs, I strongly encourage you to call our helpline. You can also visit our website, www.naminyc.org, and we'll share all of that information in the chat for you. We'll have time for questions throughout, so feel free to raise your hand or share your thoughts in the chat. Your feedback is very important to us and helps inform future events. So towards the end of this presentation, we will share a survey in the chat. If you could please take a few minutes and complete it, we really appreciate that. If you have any technical difficulties throughout this presentation, just let us know in the chat and we'll do our best to address them. And with that, I'm going to hand it over to Leah. Thank you all for being here.
Thank you so much, Aubrey and Barbara. I'm so happy to be here tonight with you all. Again, my name is Leah Harris. I am the training director at Zero Overdose. I'm also a person of lived experience. I'm a former methamphetamine user. I'm also the child of a parent who lived with addiction. We have a whole lot of addiction in our family, and I imagine that some folks in the room can relate. So we have so much to get into this evening, but I would love to know in the chat if you could just share a little bit about what brings you here today. I'll try to keep an eye on that because I am curious about who's in the room tonight, but I will get us started with this presentation. All right, so just looking at what we're going to be doing together this evening. First of all, talking about what are the trends that we're seeing in terms of overdose and the substances most frequently involved, describing who is at risk, right? Why are they at risk? And why do we really need to increase our focus on awareness and prevention? We're going to understand the primary elements of overdose risk using our handy-dandy risk formula, which I'll be sharing with you tonight. And then Aubrey started to share some resources, but we're going to talk a little bit more about where to find help and how to engage with community resources. So just looking in the chat here. Some folks saying they'd like to have this information for their community. Yeah, we also have a NAMI family match volunteer, a few folks, and family members. Beautiful. Thank you so much for sharing a little bit about what brought you here. We have a certified alcohol and drug counselor here. It's really great to see the range of folks who are with us tonight. So thank you for taking the time. All right, so one of the best ways that we can support loved ones who are living with substance use addiction is to know the facts, right? So we're going to talk about some of the facts, some of the statistics that we're seeing. But I think the really, really critical piece that we want to hit home here is that substance use disorder, also known as addiction, is a disease or a chronic condition, right, that affects thousands of New Yorkers. And addiction is not a behavior problem, it's not a moral issue, right? We're really looking at this as a chronic health condition that actually changes the brain and body. And then the other really critical piece we want to drive home is that there is care, there is treatment. It can take time, but there's many effective options available, from medication-assisted treatment to 12-step programs, other recovery programs that we'll be sharing with you all. And then I think the thing that we're also going to unpack in this training is talking about the issue of stigma and how that's impacting folks and impacting their access to care as well. So we want to look at some of these challenges. But overall, really, we want to drive the point home that recovery is possible. For many folks, it's a lifelong commitment, and it looks different for everyone. There's no one size fits all approach, right? And so as you're standing by a loved one who may be struggling with substance use disorder, it can definitely be challenging, and we don't want to at all minimize that. But one way you can really support them in their recovery is seeing them as the person, right, versus the addiction. So just want to share a little bit about our organization. We were founded in 2018, and we're a nonprofit that is really looking to curb unintentional overdose deaths through the use of overdose safety planning. And we will collaborate with states, communities, anyone, national associations, anyone who will work with us to really raise awareness and further our mission to prevent overdose events and deaths. These are just some of our partners. We're grateful that this list is growing all the time. This also does include the New York State Office of Addiction Services and Supports. And we're thrilled to be partnering tonight with NAMI on this initiative. So just again, to kind of talk a little bit about what our organization is about. It's about reducing overdose events, right? Again, by expanding access to overdose safety planning and education. And what we're really seeing as the problem here that we're trying to collectively solve is that overdose rates continue to rise, driven by, the huge prevalence of synthetic opioids like fentanyl. And that overdose safety planning is a prevention strategy. It's a proactive strategy, and it is a frontline intervention. You do not need to have any particular credentials or degrees or letters behind your name to deliver this. And our mission is really about reducing risks and preventing overdose deaths and events. So that's what we're focused on tonight. And this is our presence. We are all over the country. We hope to have this entire map purple soon, but we're really, hoping to continue to work on a statewide and community-wide level to combat the opioid crisis on a national scale. So just going into some of the data and the trends that we're seeing. So, for those of you who may not be aware, substance use or drug overdoses, apologies, are one of the leading causes of injury deaths in the United States, and they have risen over the past several decades. And we're also seeing that, the impact of opioid-related deaths in America leads to 3.1 million years of what is called life lost, right? And so that really helps us to understand that looking at these data, compared to 2019 to 2022, this has lowered U.S. life expectancy by nearly a year. And then we know that overdoses involving synthetic opioids such as fentanyl and stimulants like cocaine and meth have also increased. And we've also seen that the rate of overdose deaths from 2002 to 2022, the rate of overdose deaths increased uh, more than quadruple. So I think that's a really important thing to note. So key substance use and mental health indicators that we're looking at here. So when we're looking at 2023, 17.1% of people identifying as having had a substance use disorder in the past year. And I think looking at this, right, breaking it down to drug use and alcohol use, we see that there's 28.9 million people with an alcohol use disorder and 27.2 million people with a drug use disorder, and then 7.5 million people who had both, right? And I think that those are really important data points to kind of look at in terms of understanding the widespread impact and the fact that people are struggling, with both substance use and alcohol disorder. Then looking at substance use in the past year, we see some of the same statistics here, right? This is also 2023. 48.5 million people are identifying as having had a substance use disorder in the past year. We are looking here again at alcohol use disorder, drug use disorder really are at the top. And we're seeing that about 1 in 6 people having both alcohol and drug use disorder. So I think that, understanding, right, that we need to be focusing across all groups, right, that looking at dual addictions, right, looking at people who are struggling with multiple addictions. These are all important things to be keeping in the front of our minds. And then looking at substance use in the past year by age. So here we're looking again at 2023, and the percentage of folks age 12 and older who had a substance use disorder in the past year varied by age groups. So you had young adults having the highest rate, with about 27.1% experiencing a substance use disorder. Adults came next with 16.6% affected. And then adolescents had the lowest rate with about 8.5% of people identifying with a substance use disorder. But we're going to talk about too how young people or folks who are naive to substance use can be at very high risk, even if they don't have a lot of experience with it. And then we're looking here at substance use in the past year by race and ethnicity. So in 2023, the percentage of folks 12 and older, we're looking at these various categories here. American Indian or Alaska Native folks had the highest rate at about 25.3, and we do see that in terms of ongoing health disparities, right, that Indigenous folks do face. Multiracial people followed closely behind at about 24.3%. Followed by white folks and Hispanic folks, and Asian Americans had the lowest rate at 9.2. And it looks, here from these statistics that multiracial people were more likely than both white or Black people to have had a substance use disorder in the past year. And there wasn't enough reliable data to calculate the percentage for Native Hawaiian or other Pacific Islander people. And then looking here specifically at fentanyl, right? We're going to talk a little bit more about fentanyl. It is a synthetic opioid. But in 2023, we see about 828,000 people aged 12 and older. That's about 3% of the population. Had misused fentanyl or used fentanyl that was illegally made in the past year. And of these, it was 627,000 people, or 0.2%, used illegally made fentanyl. And it's really important to note, right, that this fentanyl might be mixing into products sold as heroin or fake prescription pills. often without people realizing it, right? So this really means that the numbers that we're looking at for fentanyl misuse and illegally made fentanyl use may not be fully accurate. So just a little bit more about fentanyl. This might be a bit of a review for some of you. But again, it is a synthetic opioid that's up to 50 times stronger than heroin, 100 times stronger than morphine, and it is the leading cause of fatal and non-fatal overdoses, right? And I think in order for us, it's really important for us to be able to dispel myths about fentanyl, especially when educating in the community. So, right, the fentanyl that is available in the drug supply is not the same as what's used in hospitals or pharmacies, right, for pain relief. And it's really important to understand the scale of the crisis with over 150 people dying daily from synthetic opioid related overdoses, as well as the prevalence in the drug supply, right? So it appears much more frequently now on drug tests than heroin. It is the leading cause of overdose because it is inexpensive, it's highly available, it can be mixed with opioid and non-opioid drugs. And I did refer to the fake or pressed pills. So it seems that the majority of the pills that are seized by law enforcement, we think it is 7 out of 10 are fentanyl contaminated. And then just to kind of have a visual or an image of this, right, a lethal dose of fentanyl will actually fit on the tip of a pencil, right? So we are not talking about large doses that can be very deadly. So, oh, actually, I wanted to just go back. I'd love to ask you all about some of the other drugs that you're hearing about in addition to fentanyl. Yeah, I'm just curious if there's other drugs that you're hearing about that are coming onto the market and causing overdoses that you're aware of, just to see if folks in the room have a sense. Yes, please, Alexi.
The K2, crank. Not the K2. There's the xylazine.
Yes, absolutely. Yeah, xylazine, also known as tranq. Yeah, K2, absolutely. Yeah, thank you so much. All right. So let's keep going. All right. So looking at the treatment gap, right? So I think that this is clear, right? We know that substance use is treatable, but what we see here in the data is that in 2023, 39.6 million adults age 18 or older had a substance use disorder in the past year, but they did not perceive the need for treatment or they did not get treatment. Or sorry, the vast majority of these did not perceive the need for treatment. And so then you also had around 2 million people, around 5.3% that either tried to get treatment or thought they should get help, but they didn't. And you have about 189,000 people who actually sought treatment and about 4.8 who didn't get treatment but believed that they needed it. So in terms of the reasons that people did not receive care, right, there are many. If you can think of others, you're welcome to put them in the chat. But it could be that they are feeling like they should be able to handle it on their own. They might not be ready to quit. They might not be ready to start treatment. They might not be ready to cut back. There could be so many concerns, lack of time or knowledge about their options, privacy concerns, fear of negative consequences, like losing their job or their family, right? So these are just some of the consequences, right, that people are concerned about. Yeah. Also Barbara sharing no insurance, right? Or people are afraid of losing their jobs or taking time off. Yeah, absolutely. Let's see if anybody else wanted to. Yeah, thank you for this comment. Shame and for women, the fear of losing their kids. Yeah, absolutely, right? Thinking about all of these negative consequences that people are not seeking out care or they're not receiving care. So yes, thank you so much, everyone, for chiming in. So just looking here, oops, I'm sorry about that. There we go. So looking at the past most recent statistics. Sorry, my boxes were covering the slide. So what we see now is that the trend continues to be moving in the right direction, right? We've had overdose deaths have been decreasing for over 7 months in a row. And that is thanks to better treatment, prevention, and education efforts, along with changes in the drug supply, especially a reduction in the fentanyl due to actions against international drug cartels. Other reasons for fewer deaths include wider access to overdose reversing drugs like Narcan, more prescriptions for medications that help with opioid cravings, and harm reduction programs offering services like clean needles and fentanyl test strips. So the preliminary data is showing around, at this point, 90,716 overdose deaths a year. It is a very, very significant drop, and we're really looking at the lowest number of drug-related deaths in 4 years. That translates to over 16,000 lives saved. So, you know, again, we do see the numbers are moving in the right direction. But of course, we cannot afford to be complacent, right? Because we still have an overdose epidemic, and there's lots of work to do, even though things are heading in the right direction. So this just gives you another kind of snapshot of the change in the United States in terms of overdose deaths. So again, things really are moving in the right direction. Looking at New York, I just wanted to highlight that we've seen a change of 24.93%. So that is really, really significant looking from August 2023 to August 2024. Yeah, just wanted to highlight that for New York. All right, and so recovery is possible. I think that's, again, what we really, really want to highlight is that there are so many adults who, you know, consider themselves to be in recovery or to have recovered. We're looking at 22.2 million people, right? So we just really want to emphasize that, you know, there's still a lot we have to do, but remembering the hope and the promise of recovery. So just wanted to talk a little bit about the spectrum use continuum. So we're really kind of looking at substance use along a continuum, and this is very different perhaps from some of the perspectives that you might have been exposed to, where one is either using or not using, right? They are it's kind of an on switch or an off switch. There's not really, we haven't traditionally looked at substance use along a spectrum. And so we could see on the left-hand side here, that spectrum could include beneficial use, right? Anything that might have positive health or social or spiritual effects, like using medication as prescribed, the use of ceremonial tobacco. Then, you know, moving from more casual or low risk use, right? That's really not affecting someone's health or social life, like, you know, having a beer on a Friday night with a couple of friends, and that's about it. And then moving along that continuum, right, to high risk, what we would say high risk or harmful risk, that's really having negative consequences for a person, friends, family, or society. So that's really what we see. And then moving to what we would, you know, see as a diagnosable substance use disorder, chronic dependence. It's the kind of high risk use that becomes habitual and compulsive, and that is despite the negative impacts on that person's life. So understanding where someone is on this spectrum is really, really important for what we, you know, we always talk about meeting people where they're at, right? And this is how we do it, right? So understanding where someone sees themselves on this spectrum, right? Meeting them there and, providing the support and care that would help them to live healthier lives and reduce their risk and their harm. And so when we're thinking about a harm reduction approach, which we're going to talk a little bit about, but that can be applied at any point along the spectrum. So I think it's really, really helpful to get a sense, if you know where someone is on this spectrum, right, we can allow for incremental change to be made, which really allows for risk reduction that's much better to suit whatever that person's own individual goals and motivations might be. So just kind of want to talk a little bit more about kind of what is an overdose, what are we looking at when we're talking about overdose, and that really is just when someone is taking more than the recommended amount of a substance, like a medicine or a drug. It can cause serious harmful symptoms or death, right? And in an overdose, what's happening is that the substances or the medications that a person is taking can overpower the brain and other organs and kind of prevent them from functioning normally, right? So for example, an opioid overdose causes breathing to slow down or even stop, kind of depriving the brain cells and the heart of oxygen, right? And this slowed and stopped breathing is usually called respiratory depression. And that occurs because the opioids are affecting the breathing center in the brainstem. So again, without intervention, overdose can and often is fatal. So then to kind of just talk about overdose, kind of thinking about the different types. So thinking about intentional or deliberate overdose, that is when someone takes too much of something on purpose, right? Their intention is to overdose. And then, of course, if it happens by mistake, we call it an accidental overdose. And it's important to also note that an overdose is not the same as poisoning, although the effects can be the same. Poisoning happens when you're exposed, right, to other dangerous chemicals or harmful toxic substances, whether intentionally or not, right, from some external sources in the environment. And then overdose deaths do remain at historically high levels in the US, and we know that opioids are involved in the majority of these tragic deaths. So just looking at risk factors now, we're going to actually unpack risk factors a lot more, looking at our formula, but really just to kind of understand that basically there can be risk factors and protective factors, right, that decrease risk and factors that increase risk. So of course, what would increase risk would be taking an amount of drugs that exceeds your tolerance level, using drugs of unknown origin, or you don't know the contents, using multiple drugs in combination, or using after a period of abstinence. We'll talk a little bit more about that. Using alone, having a prior overdose, having limited access to community resources like drug checking tools, right, test strips, or opioid overdose reversal medications like Narcan. And then what does decrease risk, right, on the other side is getting your drugs from a regulated source or testing the contents, staying within one's tolerance level, right? We talk about know your dose, using in a relaxed environment with somebody who knows how to respond, who has Narcan available, or naloxone. I'm just going to check the chat here. Yeah, George clarifying, right, that accidental or deliberate depends on the intent, right? And we will definitely talk more about tolerance, Michelle. We are definitely getting into that. Thank you. All right. So what are some, contributing factors that can impact one's susceptibility to overdose, or to addiction? Genetic factors are a big one. So these account for 40 to 60% of a person's vulnerability to addiction, including the effects of the environment, right? Also psychological factors, mental health co-occurrences, whatever those coping mechanisms might be. And then another one I wanted to mention is that parents or older family members who use alcohol or drugs, or who engage in any kind of like drug using behavior, that can also influence a young person's risks of developing their own substance use issues. And again, the earlier that a person begins to use drugs, the more likely they are to progress into more serious abuse. And then the method and the route, right? So smoking a drug or injecting it into a vein would increase, right, the addictive potential. And we will talk about method and route as well. So getting into a harm reduction, kind of looking in more depth at a harm reduction framework, I would love to get us all thinking together, just in a practical way, right? So what are areas in your life where you practice harm reduction? You're welcome to put this in the chat. So it wouldn't be about avoiding an activity where you could potentially get hurt, but really reducing your chances of getting hurt doing that activity. Understanding that all activities, right, will come with some level of risk. So thinking about the everyday ways that we practice harm reduction, like wearing seat belts, or not legally allowing people under 21 to drink in bars, right? Those are sort of different ways that we practice harm reduction on a collective level. I'll say for me, I go hiking by myself. That's one of my favorite kind of coping mechanisms. And I will always tell someone where I'm going. I'll tell them when I get there, and I'll tell them when I'm, back safely in my car. So that's another example. Yeah, so great examples here so far. Yeah, Barbara sharing wearing a helmet when riding a bike. Yes, attempting to reduce the amount of sugar you eat due to health issues. Yep, waiting for a green light to cross. Yeah, I love this one, Michelle. Adding water to my apple juice to reduce intake of sugar. Yeah. Wearing my seatbelt. Yes, absolutely. These are all great examples of harm reduction. Thank you all for chiming in on that. So, harm reduction is very much a practical and transformative approach that really incorporates public health strategies that are driven by the community, including prevention, risk reduction, health promotion. It's really about empowering people who use drugs and their families to have the choice to live healthier, self-directed, purpose-filled lives. So we're talking about a non-judgmental approach here, and that we're really trying to just enhance quality of life. And I talked about this a little bit earlier, but understanding that behavior change is an incremental process, right? It takes time. Complex social factors, right, as we just talked about, right, can influence vulnerability to substance use and substance-related harm. We also really want to empower and support and uplift those who use substances to be the primary agents in reducing the harms of their substance use. And these are 6 pillars of harm reduction, really, that kind of underlie the entire framework. So first of all, as I just mentioned, they're led by people who use drugs and those who have lived and living experience, right? Because they're the ones who know the most, right? What works and what doesn't. Embracing the inherent value of people, right? And that's just remembering that everyone deserves respect and care. Deep engagement and community building. So it's just about real community connections, right? That it takes a community to reduce harm. It takes that collective approach. How do we support each other and create communities, where people are belonged and cared for and have what they need? It's also about promoting equity and rights and reparative social justice, right? Making sure that people who use drugs are not treated unfairly or discriminated against, and they have access to what they need. And then we want to look at offering the most accessible and non-coercive support, right? Just making help easy to access, No judgment, no pressure, just support whenever somebody is ready for it. And then focusing on any positive change, right, as defined by the individual, right? That's really, really critical. It's about celebrating any progress, right, big or small, right, and understanding that each person can set the path forward at their own pace, right, and define what recovery or what healing looks like for them. And I agree with you, Michelle, about harm reduction being such a really important approach. You were saying it supports self-determination and autonomy. Yeah, 100%. Yes. Thank you so much. Yeah. So then kind of thinking, here's a definition from the National Harm Reduction Coalition. Definitely encourage you to check them out if you're not familiar with them as a resource. But yes, so again, looking at harm reduction as a whole set of, it's a philosophy, it's an approach, right? But it's also a set of practical strategies and ideas that are aimed at reducing the negative consequences associated with drug use. So we've already kind of discussed, how harm reduction really views drug use as this complex, multifaceted phenomenon, and that it's encompassing this whole continuum of behaviors that we've discussed, and that it acknowledges, right, that some ways of using are absolutely safer than others. And so we're really sharing this to convey that harm reduction has been the emergent way to treat substance use. Some of you who are Generation X like me might remember the era of, this is your brain on drugs. And I remember the Scared Straight program, right, where they would try to frighten young people into stopping. They would take them into prisons, and right, that these kinds of approaches we found have been not really effective. And so we are looking at moving away from these old school, more punitive, fear-based approaches to have a different approach. So we're not going to assume that people will stop or want to stop using, but really we're asking, what are the strategies to reduce the negative consequences of use, right? And we're not only focusing on abstinence, but we absolutely acknowledge it as an option, right? So kind of moving away from that kind of all or nothing thinking and viewing substance use right along a continuum. So I would love to know, we've talked about some harm reduction strategies so far. We've talked about test strips. We've talked about Narcan. But I would love to hear what are other harm reduction strategies or services that you're aware of. You can pop it into the chat or come off mute. What other harm reduction strategies do you know about? I love it. NAMI. Yes, great answer. Syringe exchange. Yes, absolutely. Yes. And I will add some more here. Let me see, just see if anybody else is responding. Yeah, I love this. Yeah, PrEP as prevention, acupuncture, absolutely. Yeah, crisis text line or 988, Narcan kits, yes. Harm reduction, works.other or .com. Oh, that's a great resource, Gloria. So yeah, so here's some of them. We've started talking about these, right? Safer substance use education, overdose prevention education, medications for opioid use disorder. Yeah, I love this, getting involved in community events, right? Being connected to community. Thank you for that. Yes. Fentanyl test strips, managed use, naloxone or Narcan, access to sterile equipment, and drop-in services. So that just gives you a sense, right, of some of the various harm reduction strategies, including, we're going to be focusing tonight on the overdose safety planning and the prevention education aspect of this. So I wanted to just talk a little bit about stigma. And, I think a lot of you, may be very familiar with this, but I just wanted to share a little bit about what we're talking about specifically in terms of substance use, right? So for those who use drugs or alcohol, stigma might mean believing that they are dangerous, that they are not able to get better, or that they are somehow to blame for their situation, right? And where does it come from? It comes from these outdated ideas and misconceptions that we've been talking about, the two eggs in the frying pan, this is your brain on drugs. The ideas that personal failing, addictions are personal failings rather than a chronic health condition that can be treated, right? So ideas that this is a moral issue are still very prevalent in our society. And science shows us, right, again, that addiction is a long-term disease or a health condition that people can absolutely recover from. So I think it's really, really critical to think about how stigma actually affects people who use substances. So I already brought up avoiding help, right? That people, if they feel that they'll be judged or that they're unworthy, they might not seek help. If there's negative reactions or stigmatizing views from society, right, that can cause people to feel pity or fear or anger or push folks away who use alcohol and drugs. And then the healthcare impact, right? So stigmatizing language can affect how healthcare providers view and treat people with substance use issues. And so you can see here on the right-hand side, it's like this vicious cycle, right, of stigma where it's loss, it's loneliness, it's shame, discouragement, fear of getting help, losing jobs, homes, friends, right? The isolation that comes from that, right? That this is just this cycle that people can really end up stuck in. So just kind of wanted to raise some awareness, right, about how this us versus them and how these negative attitudes have such real world consequences on people's lives. So wanted to talk a little bit about language, right? We want to try to use neutral terms, right, that describe the behavior rather than value-laden kind of terms, right, like clean and dirty, right, with those kinds of implications that they have, right? So I think it's really, really helpful to kind of think about person first language, right? So instead of addict or junkie, you could say a person who has a substance use disorder, a person who has problems with alcohol and drugs, a person who uses drugs, or clean, right? That could refer to people or tests, right? So we might think about just using the very, neutral terms, right? Negative test, abstinent from drugs, not taking drugs, maintained recovery. And then relapse, right? So terms like lapse and relapse are commonly used, right? But they can be stigmatizing, right? Because they imply failure and choice, right? And we don't say really about any other health condition. I haven't been able to think of one that the person relapsed, right? If someone has cancer, we don't say that they relapsed or any other health condition. So thinking about more neutral terms like return to use, recurrence of use, right? And then abuse, right? We do still see that term quite a bit, but there has been some research to show that it does increase negative attitudes in healthcare providers when we use the term abuse. So really just to kind of, I really want to share all of this to say that, using this respectful language is so critical to reducing stigma, right? And it might take practice or change in how you talk about substance use, but I think it's so worth it to make a positive impact on people who are struggling. And of course, I just also want to say that if people use this language to describe themselves, we're not correcting them or shaming them or anything, but it's just a matter of modeling destigmatizing language. But I would never recommend correcting people or telling them that they're wrong in terms of how they're referring to themselves, right? So I just wanted to make that point really clear. So, we've laid out the trends, we've laid out kind of what harm reduction looks like, and now kind of looking at what are the opportunities to intervene and what are the missed opportunities. So we know in the US, for every one fatal overdose, there are approximately 10 non-fatal overdoses, right? And this tells us that many people are surviving overdoses. And these kind of near-death experiences can often be a wake-up call, right? But the thing to keep in mind is that if people don't get the right kind of care or treatment afterwards, they could experience another overdose, and that could be a potentially fatal overdose. And then we see in 2021 to 2022, almost 600,000 emergency department visits for non-fatal overdoses. And as we talked about that looking at 2022, 85% of people with a substance use disorder did not receive treatment. And then really what we're talking about is that, approaches that are driven by data and tracking can really save lives, right? Understanding the place of death, where the naloxone was administered by EMS, the day and the time, right? Things like this can help to better identify missed opportunities and how to intervene. And then I just want to really highlight, right, that we all play a critical role in overdose prevention. We've laid out, kind of what we're seeing, and clearly there is a lot to be done to stem this tide, but, including a focus on treatment and prevention. A lot of you are familiar with Narcan, naloxone. We've talked about that, and we've seen this huge adoption of Narcan, which is very, very hopeful. But the idea here is to try to go a little further upstream, right? Is to reach people before they've overdosed with overdose prevention strategies like overdose safety planning, right? So I think that's another really important point that we want to bring up. And the evidence does show that people who've died from opioid overdose often have a clinical encounter of some kind, right, leading up to the tragic event that could have presented an opportunity for intervention, right? So 64.7% of overdose deaths had one potential opportunity for intervention. And so part of what we're trying to do in terms of moving upstream, right, and preventing overdose events, right, preventing overdoses before they happen is through screening and safety planning. So that's what we're going to be talking about for the rest of our time together. And then, right, that with that, right, we want to have collaboration among professionals and communities, right, because this is not anything that any one person can do, one agency can do, one state can do, right? It's really all of us working together. So getting into the overdose safety planning itself. It is a collaborative brief health intervention. It is evidence-informed and applicable in a whole diverse range of medical and public health adjacent settings. So it is recommended by SAMHSA in their 2023 practice guide and in their 2024 overdose prevention toolkit. Many other sort of medical standards of care, New York Offices of Addiction Services and Supports, information, the National Council for Mental Well-Being, the National Institute on Drug Abuse. So we also see it in the opioid overdose reduction continuum of care approach. So it's really being adopted as an emerging best practice across a whole variety of different settings. Also, I forgot to mention within the Lifeline, the 988. So this is just one resource that we offer. It's an overdose risk questionnaire, and we offer this in conjunction with our overdose safety planning tool and our harm reduction education. So this questionnaire is not like a scoring screener or an algorithm, but it's really more of a set of questions to guide the conversation with whoever you're talking to, and just to really get that conversation started and get engaged in understanding risk factors. So it touches on high risk substances, right? That we've kind of talked a little bit about those: fentanyl, methadone, heroin, right, et cetera. Overdose history, right? As we just laid out, if someone has had a previous overdose, that puts them at a higher risk for another overdose. We're looking at precipitating factors, comorbidities, right? So are there any health conditions that could increase that person's risk of overdose? Like COPD would do that because it interferes with breathing already. So also thinking about, are there recent stressors that have happened to this person, like the loss of a loved one or financial hardship? Could be relationship issues, incarceration, right? As well as patterns of substance use, right? So what, how, when, right? All of these kinds of things. And we're going to go a lot more into looking at all of these different risk factors. So this is the actual one-page overdose safety plan that we're going to be talking about. And it's really looking at, if you're familiar with the Stanley and Brown suicide prevention safety planning, or any aspects of suicide prevention safety planning, this might look familiar to you. But it is really designed as a brief intervention, right? It's one page. It has a harm reduction focus. It is based in the best practices like motivational interviewing, right, which is used to support people in their process of change. And I think I mentioned already, it's drawn from suicide prevention. It's informed by lived experience. And the idea is that we are not doing this for someone or to someone, but with someone. So the idea is that this would be done collaboratively, whether it's a provider, friends, family, right, whoever's working on this with someone. And it's not a one and done document, right? It's meant to be updated over time. And if this is in the, a clinical setting or a healthcare setting, we want it to be shared, with consent, so that it can improve collaborative care and continuity of care. So it includes 7 steps. Step 1 is talking about the things that put a person at risk for overdose, and we're going to go through that. Steps 2 is pairing those risks with a harm reduction strategy that like one of the ones that we've talked about, or other ones. Steps 3 and 4 is really those protective factors that we talked about. How does that person kind of keep themselves well and belonged and with people? And then 5, 6, and 7 are really referrals to treatment, right? So that's resources, looking at motivations, and next steps to reduce risk. So we have envisioned this overdose risk formula as a way to frame the conversation, right? To get that conversation started about the various risks, as well as the possibilities for reducing them, right? So this overdose risk formula takes into account 3 main themes. So first, patterns of drug use and the effect of the drug on the body, the mindset of the person, and the setting in which this drug use occurs. So let's kind of break these down a little bit. So thinking about amount, right? You'll want to consider or ask or have conversations about the potency of the substance, right? The route of administration, certain preferred practices, right? How are they using the substance? Anything that would sort of negatively impact their, or adversely impact their overdose risk, right? And so all of these, which are included in the risk questionnaire, get at the effect of the drug on the body, right? And its association with overdose risk. And then you want to really ask about, what is the mindset of the person at the time of the use, right? What is their mental state when they're using? Why are they using? We're trying to get at all of these things. And then with setting, where is the person using and who is present in that setting? So when we're thinking about overdose risk, we want to think about the drug, the mindset, and the setting. So we're going to just unpack each one of these a little bit more. All right. Just looking at the chat here. Oh, I'm so glad y'all are having some good conversations. Yeah, I love what you've said here, Marina. I like to say I'm X months strong. Yeah, that's beautiful. Going back to thinking about recovery. So, so we're just going to go through and look at each one of these in a little bit more detail. So looking at the amount, right, and that's really the considerations that impact the total amount of opioids that the body is processing. And when I think of the amount, I like to picture it like a snapshot, right? When we think of overdose risk, it's the amount of opioids that are attaching to the brain receptors at any given moment in time. So we're looking both at the volume of the drug being consumed and the duration of the effect, right? And mixing substances is a very, very significant factor, right? It's additive, right? So that's why we say 1 + 1 does not equal 2. In this situation, 1 + 1 equals 5, right? Because it can result in a bigger effect than anticipated, right? So explaining this in terms of the total volume that's consumed, the strength and the dose, well, those are all the things we're trying to find out, and whether that person is mixing substances, right? So mixing different substances like Xanax, Klonopin, alcohol, right? Opioids, that slows the breathing and the function down. If you look at opioids in combination with stimulants, this is like putting the foot on the gas and the brake at the same time, right? And this relates to individuals' tolerance in that they might be unaware that they're taking in opioids that they have a low tolerance to. So these are all areas where we can try to ask questions and really get a sense of, you know, how much does the person I'm talking to know about these risk factors, right? And can we learn more together? I'm just checking the chat here. All right. So then looking at route. So this is basically each one of these in this risk pyramid when we're looking at the route, how the person's using the substance. It's basically the approximate time from use to the onset, right? Depending on how that drug is being administered. So the risk of overdose increases inversely to the time of onset. So the shorter time of onset is a higher overdose risk. So that's why we have, you know, intravenous IV injection at the top is right 20 to 60 seconds, followed by smoking, right? There's very, very high overdose rates involved with smoking, given how quickly, right, those impacts are felt. So how someone is ingesting the substances is affecting the speed at which it's metabolized, reaches the brain, and the duration of that effect. So, you know, thinking again with a longer acting effect, right? Rectal 5 to 10, injection, intramuscular injection, 10 to 20 minutes. Subcutaneous, sometimes known as skin popping, that's like 15 to 30 minutes to come on, with snorting and consuming orally being, you know, the longest acting. And so I think people are often reluctant to change their method of use, right? The reason is that they have experience with it. It gives them the effect that they're seeking. So it can be challenging to have these conversations and to contemplate changes in route, but this is absolutely one way that a person can reduce their risk, right, in terms of changing their route. So then getting to your question, I did not forget, we are talking about tolerance. So tolerance, what we're really looking at here is how the body adapts to a regular use of a drug over time, right? It's when the body gets used to a substance, so either more of it is needed or a different substance is needed to obtain the desired effects. So it's so important to understand that tolerance will decrease with periods of abstinence that can be as short as 48 hours, right? So if someone is incarcerated or in any kind of a restricted healthcare setting, right? for as little as 48 hours, right, that could impact their tolerance, as well as during periods of using less. So I use the example of if someone is prescribed a chronic pain med, most folks will take them as prescribed, but some people may take more of the prescription when they first get it, right? So towards the end of the month, they have to wean themselves off or take less over time, and they may supplement with other prescriptions or substances, but that tolerance will change over the course of the month, right? So if they use more than prescribed at the beginning of the month, after their tolerance has decreased, they're at an increased risk of overdose. And we'll definitely give you all a copy of these slides and the safety plan. So thank you for asking about that. So really understanding that when we understand how quickly tolerance can decrease, then we recognize that transitions of care are really high risk periods, right? So again, from inpatient to outpatient, incarceration to the community. So these are really critical things to be thinking about as regards tolerance. And then we want to move to the just kind of looking again, just reviewing the risk formula. So we've talked about amount, route, and tolerance, right? All of those combining to influence how the drug is affecting the body. And now we're going to look at mindset and setting. So looking at the mindset, this is the emotional state of a person when using drugs as well as the purpose. So I would love to hear from you all. What are some of the reasons that a person uses drugs, right? There's so many reasons. I'd love to hear from folks. Of course, when we're looking at opioids, right, they are maybe literally used to relieve physical pain. Yeah, absolutely. Someone sharing escaping, right? Escaping from reality. Yeah, difficulty coping, numbing feelings. Yeah, can't find other ways to cope. Yeah, coping from trauma. Yeah, absolutely. Yeah, just wanting to forget. Yep. They may also use them for positive reasons, like to celebrate or have fun or, I don't commemorate an occasion, right? But yeah, I think that this really does cover the range of people, some of the range of reasons that people use substances. Yeah, someone else sharing. Yeah, because they enjoy it. Yeah, you got at what I was saying. They are physically suffering from unmedicated pain, right, and are auto-medicating. Yeah, absolutely. Yeah, and then, for some folks, right, it's liquid courage. Absolutely. So thinking about those, right, those different reasons that people use drugs. And then also we need to acknowledge, right, the explicit intersection of suicide and overdose. We may not always hear someone explicitly saying that they are suicidal or that they want to die, but you might hear from people who are revived after an overdose, I didn't care if I woke up or not, right? And I think that's why it's really, really important for all of us, right, to have as much comfortability to talk about suicide and overdose together, right? Because they can be very, very interconnected for folks. But the good news is that overdose safety planning really is a first line of treatment for both suicide and overdose. So thinking about, right, how does mindset and that state of mind that the person is experiencing while they're using, how does that impact their risk, right? That's a big part of safety planning. And then looking at setting. So setting is really referring to elements of the environment, right? Where the person is, who and what is around. So, right, some of these considerations regarding setting, using alone, right? We know that that's one of the biggest risk factors right there. So, but using alone could look very different, right? They could be using alone in their home in a quiet setting where they're not rushed. Or they could be using alone, let's say in a public bathroom, like a Starbucks bathroom or something, and people are lining up and knocking on the door, and the manager is going to be called soon, right? Like there's a sense of being rushed or afraid. So thinking about that, right? Is the location familiar? Is it unfamiliar? Is Narcan available? That's another consideration. Is there Narcan in the setting? I was so pleased. I went to a local coffee shop the other day, and they had Narcan there. They had Narcan kits for people to take, and they had it available at the coffee shop. And they're gonna have my business from now on. But right, is there that availability of Narcan? And then what kind of type of substance are they having access to? What is the purity of it, right? And then what route of use is available to them in that setting? So those are all the kinds of considerations you would want to look at in terms of setting. So I want to do a brief review of the actual safety plan itself. But before I do that, I just wanted to pause because I know I have thrown a whole lot of information at you and see if there's any questions about the overdose risk formula, uh, about amount, route, tolerance, mindset, setting. Any questions or observations about any of that so far? Well, I trust that you will pop it in the chat if you do have any questions. And we will keep going. So basically looking again at the safety plan, right? It's a one pager. So we're just now looking at step one. And in this conversation, right, you would be, hopefully able to identify some of the risk factors, right? So let's say somebody, one of their risk factors is that they're using multiple substances, right? That could go on the plan, or that they're using alone, that could go on there. So just kind of thinking about all of those different risk categories that we've talked about could go in here. And then in step two, right, this is really looking at specific harm reduction strategies that can be paired with the risks that are identified in step one, right? So if the person, is using a large amount at once, you could maybe encourage them to use smaller amounts over a longer time, right? Stretch that out so that there's not as much hitting the brain at once. Or using one substance at a time, right? If that person is using multiple substances, testing the strength of the pills, right? Having access to those test strips. Being able to identify what is in the pills. And then we've talked about start low and go slow, right? That those are really common harm reduction pieces of wisdom, right? And know your dose, right? So those are some strategies that people can use to, reduce the risks that they're experiencing. I'm just gonna check the chat. Oh, beautiful. Thanks for answering the questions, George. So then when we're thinking about the safety planning, so let's say, talking about the setting, right? If that person is using alone, what are ways that they could avoid using alone or be extra cautious when using alone? Making plans for someone to check on them, for example. They could use the Never Use Alone hotline. They could keep naloxone on hand, right? There's so many strategies that could be applied, whether it's right the setting itself or the strategies that people could employ. So then really steps 3 and 4, like we talked about, is just protective factors, right? Things they can do in addition to lower their risk. Things that they would like to do more of to stay well, meditate, read, go for walks, right? Whatever that might look like, things they do to take care of their physical and mental health. And then step 4 is really just about community and connection, right? These are people that they could consider that they could ask for help, people who can support their wellness, people who can cheer them on in the changes that they're trying to make, right? And so, having those names and those phone numbers handy for folks to, because I think the thing to remember, so often safety planning is so helpful because in a crisis, I might forget a lot of these things, right? And having a picture of this in my phone or having access to this, right? We're hoping to develop an app, but for now, right, having this when I'm having trouble thinking clearly, it's already been planned out. So thinking about who are those folks in people's lives who can support their wellness. And then steps 5, 6, and 7, that's again really about connecting people with care and getting at their motivation. So, this would be the people in step 4 would not step 4 would not be people necessarily that you would call on in a crisis. I mean, maybe, but here is really where you would look at the professionals and the agencies. We have the 988 suicide and crisis hotline on there. But yeah, just connecting them with local resources. And then step 6 is really getting at that motivation, right? So maybe people haven't talked about wanting to die. Maybe they have, but it's really kind of what is the reason that you want to pursue change or get into recovery, right? And if somebody says, it's for my family, it's great to see if they're willing to talk about what is it about their family that makes them want to stay sober, right? Or stay abstinent or whatever their choice might be to reduce their use, to manage their use. That number one reason, right? Maybe I want to be there for my family. I want to show up for them, right? So trying to get that as specific as possible. And then step 7 is really just one thing a person can do to reduce their risk. Ideally something that can be done quickly, within the next 24 hours. I will get xylazine test strips. I will get some Narcan, right? I will save the never use alone hotline in my phone, right? Whatever kind of quick actionable thing that they can do to reduce their risk. And so just, wanted to share a little bit of our training outcomes. So we work with all kinds of folks. We've trained folks across the whole behavioral health workforce. And 95% of the participants in our programs or our trainings recognized that it's really important to have these kinds of screening conversations or to have conversations about overdose risk in primary care settings. And then 48 of the providers reported routine use of overdose prevention with their at-risk clients. So people are recognizing that this is very important, but only half of them are doing that. And we have to believe that they just don't necessarily have the skills or the confidence, right, to do it. But we did find that post-training, 92% of folks said that they plan to integrate it into their care and their work with people. And they think that it would be well received by the folks that they work with. 100% thought it would be well received. So, these are very encouraging outcomes. And we just wanted to share a little bit of the opportunities for collaboration. If anybody would like us to come to your organization or your agency. We also provide technical assistance in addition to training. We provide coaching. We support people to really integrate overdose prevention into everything that they do. And then we also partner with people on grants as well to try to get overdose safety planning to their organizations and communities. So I'm just going to check the chat here, see if there's any questions. Oh, great. Thank you, George. Thank you for answering everyone's questions. Fantastic. All right. And then just one thing this is just a final thought. Is that, this has all been focused on supporting family, friends, loved ones. It's so critical, I know we all know this, but I think it really goes without saying the importance of caring for ourselves, right? And like getting support for yourself if you need it. And Barbara and Aubrey shared some great resources. Just really thinking about your emotional stability and that, you know, really caring for yourself, you know, allows you to be better equipped to work with crises, arguments, right? To really shift interactions with your friend or family member who's struggling. And it may, some people talk about feeling like, oh, I have, you know, they have it so much worse than I do. Like, why, you know, I don't want to focus on myself. But so it may seem counterintuitive to support yourself, but it is so, so crucial. And I know, you know, we're in the right place with NAMI and you all get that, but I just really, really wanted to say that. And then also just the other thing I wanted to share about the safety plan is don't feel like you would have to sit down with someone and necessarily go through all 7 steps, right? As a community member, that may or may not be in your capacity to do. But any kind of conversation or any kind of safety planning is better than none, right? Like having conversations about overdose risk, talking about harm reduction strategies and resources, you know, sharing community resources, all of those kinds of things. But I don't want you to think that you have to do this perfectly. It's really just getting that conversation going is better than no conversation at all. So I really wanted to highlight that. And just some additional resources in addition to the ones that were mentioned and shared by Barbara and Aubrey, right? Many of you have heard of Al-Anon, Nar-Anon, Smart Friends and Family. There's also CRAFT, which is another approach to supporting families. And wanted to share, there's also a harm reduction resource locator. So if you want to locate resources near you, it allows you to search by your zip code for that. So that's basically what I have for you today.
Thanks, everyone. Thank you, Leah, for sharing all this important and life-saving information with us tonight. I think we can all agree we truly appreciate it, especially your courage and dedication to raising awareness around this issue. As we mentioned at the beginning and throughout the chat, we have a feedback form, and it's very important to us and helps us inform future public education events. So we encourage you to take a few minutes to fill that out. I believe Barbara has just put it in the chat again. As always, we love having as many people join these events as possible. We have had people from all 50 states, from Puerto Rico and 36 other countries come to our public education events. So always recommend bringing a friend. And know that you can always call our helpline to learn more about our virtual programs. They're available to New Yorkers and people living outside of New York. If you have any questions, call our helpline or email or chat us online. And then finally, I just want to share that we do have our NAMI-NYC Walk and Mental Health Fest coming up. It's going to be Sunday, May 18th. So we definitely hope to see you all there. And I will put a link for more information about that in the chat. But for now, we definitely just appreciate you all coming, and we hope you have a great night.